of the Cardiac Surgery Department at the Lancisi Cardiovascular Center, Polytechnic University of Marche, Ancona, Italy. And I'm very glad to be here today and to give you my warmest welcome to our first virtual international meeting on minimal invasive and transcatheter cardiac surgery from theory to practice. If I can have my first slide, please. I must say that 1 year ago, I had a different plan for today. And the plan was that of having you all here in Ancona, in the place where I live with my family and where I work with my team for a 2 days meeting with a large international faculty focusing on minimal invasive and transcatheter cardiac surgery for the treatment of patients with valvular heart disease, with atrial fibrillation, coronary artery disease, aneurysm, and heart failure. But probably the most pleasant part of my plan was that of inviting you all here for a social dinner, the participants and the faculty in this special and beautiful place in Ancona. But at the beginning of this year, it was immediately clear to me that the coronavirus didn't like my plan at all. And we all know what happened, the huge loss of human lives we had, and devastating emotional impact that had on us, on our families, on our lives. We also know how that virus could adversely affect the organization of our hospitals, the drama of the COVID patients, non-COVID patients, and how we had to reduce to the minimum our surgical activity. We also know how the coronavirus affected our social relationship, this crazy social distancing. But I must say that we immediately realized it was important to react, to be resilient. And that was at the end of February when everything was starting here in Italy. So we can stay home, but we can't stop. We don't stop, and we have to move on. So I must say that here to cancel the meeting or to postpone the meeting has never been an option. So we immediately decided, when webinars were not so common, to convert our in-person meeting into a virtual meeting. And best option for us would have been that of broadcasting our conference from a global platform. So what better partner than CTSNet? And that's what happened. And if that happened, I must say thank you to many persons, but probably to two persons in particular, two friends now. One is Professor Tom Guyon from Houston, and the other one is Graham Rush, the executive director of CTSNet. They immediately well received my proposal to work together and and it was can I have the previous slide, please? This is virtual, but I see this is real. So can you go back to my, yes, thank you so much. So together with Maddalena Bracchetti from Nomema Congress, we had to rethink completely in 10 weeks this virtual event. It was a lot of work, a lot of fun, a lot of calls, emails, and I think I must be very grateful to them. Also, I like to thank Dr. Bashi and Dr. Hirmat from the Indian Association of Cardiothoracic and Vascular Surgery. They're streaming this event from their website. So I'd like to thank you very much for the friendship and for your partnership. And then the sponsor, I asked them at the end of February, at the really beginning, to support this educational project, and they responded immediately. Yes, we want to be part of it. We want to be with you. We can count on you. So I'm very grateful to them. It meant a lot to me. So please take your time to visit our virtual exhibition in the website of this Congress. You can get important information about modern products and technologies that are so important to get good results for our patient. And this is the faculty. I'm not going to introduce none of them, and not because I'm not respectful enough. This is just because I don't need to introduce none of them. If this was a basketball NBA game, this would be the All-Stars game. So I'm very honored to have them with me. And their task will be that of sharing with you their techniques, their approaches, their opinion, their vision to share their vision of cardiac surgery that we all agree here should be going in a minimal invasive and transcatheter direction. Logistics, we're going to have 2 sessions, 2 hours each, one today, focus on the aortic valve, and one tomorrow at the same hour, focusing on the mitral valve. I don't think you need many more information. In fact, I think you know the password for your Wi-Fi connection. I guess that the coffee breaks will be quite liberal, but what I want to do is to invite you, the viewers, the participants, to really be with us. My dream is to build a very friendly, interactive, relaxed atmosphere to discuss together about our specialty and about minimal invasive and transcatheter cardiac surgery. So please help us to make this event very memorable. And this is my last slide for this introduction. To confirm, I'm a resilient person. I haven't abandoned my original plan yet. This is to warmly invite you to come to Ancona next June 2021, for our second minimally invasive and transcatheter cardiac surgery. Very probably we will have a couple of sessions that will be streamed by CTSNet. They don't know it yet. I haven't discussed that with them yet. So this is my live kind request, and to collaborate also for the next year. I don't want to take more time to the session, so it's my great pleasure to introduce the first 2 moderators for this aortic session. So we will have Professor Tom Guyon from University of Texas, Houston, and Professor Mauro Rinaldi from the University of Turin, Italy. Tom, Mauro, please.
Thank you, Professor Tiziano, for your leadership during these difficult times, and I want to thank CTSNet for broadcasting this event. Welcome attendees from around the world. Welcome speakers from around the world. This is the first time that we're having a true global community with speakers from around the world and a community from around the world. We have roughly 2,000 attendees from roughly 100 different countries. I wanted to start off with 3 characteristics that I think define our field: resilience, perseverance, and innovation and innovation. I want to start off with a story that I think many of you can empathize with. I think many times, hopefully not many times, but there are times where you're stuck in the operating room. It's been a long case, a difficult case, 5-7 hour case. You're having to reclamp the aorta just to fix something. You want to leave, but you can't. You see 2 different scrub tech teams come through. You see anesthesia take their lunch break and then their dinner break, but you stay, not because you want to, because you have to. We're resilient, and we are here to preserve, we're here to take care of our patients because the patients need us and they come first. Similarly, with the COVID crisis, we're resilient, we're moving forward with this meeting. And again, I want to applaud Dr. Tiziano, because if there's any small victory from COVID, it's that we won't let the virus dictate our terms. We're moving forward with the meeting that was originally scheduled in Ancona, and we're glad you can join. The third characteristic of surgeons in particular is progress and innovation. If we're doing the same thing now that we did 50 years ago, we're not making progress. And that's why many of you are here today, to learn and expand, and to learn from one another, and to learn from our global community and from our friends. With that, I'll start the conference. I want to introduce the first concept, a rapid fire session. With that, we'll have a poll, and the poll will be how we like to do minimally invasive AVR. If we can have the poll question up, please. And if you can scroll down and vote your preference of how you prefer to do a minimally invasive aortic valve replacement. Can we have the poll question up, please? So vote your favorite among these approaches, and during the rapid fire session, we'll have speakers give 5-minute talks on each of these approaches, and then we'll also give the results of the poll. So again, you can scroll down on your screen and vote, and if you do that now, that would be great. So our first speaker in this session really does not need any introduction, and this really is a global community. Our speaker is from Philadelphia, Dr. Joe Bavaria, and he's going to talk about trends and real-world outcomes in transcatheter valve interventions, report from the STS ACC TVT registry. Dr. Bavaria.
Thank you very much. I hope you can hear me. Tom, everybody can hear me?
Yes,
We can
we
hear
hear.
Great. So what I wanted to talk about today is the new insights and perspectives from the U.S. National TBT Registry, which is a very large data set. My disclosures really are on this slide. The main one, though, is that I'm the chairman of the TBT Registry Steering Committee. Also in my disclosure is that I love Tavor and totally believe it's revolutionary, and that's an important disclosure. The history of the TBT Registry is that it was a collaboration between the STS and the ACC in the United States at the request of the government to create a national registry when Tavor was first initiated in the United States. The module has the TBT registry has 3 modules, including transcatheter mitral repair and mitral valve and valve. But I'm only going to speak about Tavor module today, which is the largest module. So the TBT has multiple stakeholders, as you can see here. It is a truly a kind of a national input registry, including academic medical centers, the research community, different corporations, the societies, and the government in multiple dimensions. I like to start with this slide, which I like. Is science tells us what we can do, guidelines tell us what we should do, and registries tell us what we're actually doing. So first of all, in the United States now, we have actually over 600 and actually over 700 Tavor sites as of yesterday. And the United States has a Tavor site for every 68,000 people over 65, which is more than any other country. And this is kind of the map. So they're all over the United States. So the first part is what is a snapshot of the United States practice patterns based on the registry data, which is hundreds and hundreds of thousands of patients. So as you can see, this is a slide looking at total Tavors, and it's through 2019. And you can see that we're looking at 73,448 Tavors in the United States, and it's been a very significant increase over the years. And the red and pink boxes are the Tavor valve and valve, which is also increasing. As of the last data harvest, the average Tavor site in the U.S. had 105 cases per year. Interestingly, as you can also see there, the transcatheter mitral, only 20 transcatheter mitrals, which is MitraClips, per site, which is interesting. This is a snapshot of the aortic valve universe in the United States based on the TBT registry and the STS national database. The TBT registry captures 97% of all cases in the United States, and the STS database captures about 93% of all cases. So you can add about 5 to 8% on these numbers. But what you can see is that for the first time in 2016, Tavor outpaced standard AVR. And what you can also see is that this year, in 2019, Tavor outpaced the entire AVR universe. In other words, all isolated aortic valves, all double valves, all AVR others, and Bentals, and basically every kind of aortic valve operation. So this is a very important slide, which you can also see in this slide on the surgical AVR side, is that some of the, like AVR CABG and AVR others, and even Bentals are increasing, so it's actually not as bad as I would have thought, to be honest with you. This is important data regarding the usage in the world. The Tavor age, I'll go through some slides, just again, snapshot of what's happening in the United States based on about 400,000 patients. The Tavor age is coming down. It was 81 in 2000. It'll probably be about 80 in 2019. Remember, the average age of low-risk trials was 74, so it's a very big difference. The data is now categorized by patient risk as extreme and high risk, intermediate risk, and low risk. And we capture that. The median age, as you can see, is 77 for low risk patients, 80 for intermediate risk patients, and 81 for high risk patients as of last year. This is a look at the registry and also the Tavor valve-in-valve procedures. And you can see that result, which I actually showed already. The Tavor valve-in-valve is increasing quite dramatically as well as Tavor. V&V is an important part of Tavor at about 6 to 7%. This is interesting. The heart team reason for the procedure is captured in the registry. And what you can see is that intermediate risk and intermediate risk is the biggest, and we still have a lot of high-risk patients, but we're increasing our low-risk patients, and when we get the full 2019 data set, based on what the reports were at the ACC low-risk trials, we'll probably see a big increase in low-risk patients. Tavor length of stay has actually decreased dramatically down to 2 days. This is a huge success in the country based on the database, and is now down to 2, and it's even only 1 for low-risk patients. And it's like, as you can see here, low-risk patients only 1, the rest of them 2 for length of stay. This is actually a very interesting slide as well, showing a progressive decrease in STS score for AVRs. This is for Tavor, and you can see that the STS score is going down, and as of last half of 2019 was only 4.7 STS score, and it's continuing to go down. So there's lower risk patients each year. This is the median STS score. I think what's important about this slide is that the STS score for low risk patients is about 2.9. And for high-risk patients, 6.2. This is a snapshot looking at the access site. And basically in the United States today, with over 400,000 Tavors, about 95% of them are transfemoral, which is the most important point. TF dominates. What also shows is that this is alternate access, which is really only 5% of the cases in the United States, but there has been a big increase in axillary and left subclavian carotid approaches, and a very significant decrease in transapical and direct aortic cases. So now let's take a look at something a little bit more controversial, which is real-world outcomes. So first of all, we are getting better. This is Tavor in-hospital major life-threatening bleeds, and the results are getting better and better each year. But however, there's been a little bit of a flattening over the past 3 years. So that's Tavor major life-threatening bleeds. One of the bigger issues here is stroke. This is again a data set of 400,000 patients, and what you can see is that stroke rates are basically the same. This is a very significant problem and something that we take very seriously on the steering committee of the TVT registry for the United States of America. As you can see, cerebral protection came in late 2017, and we have now thousands of patients with cerebral protection devices, and our biggest commitment over the next year is to analyze this data set and see if it makes a difference. So the stroke rates are very flat. There's no real change in 7 years. This is very important if we're going into low risk in a big way. One of our biggest challenges. These are real world data. And as you know, the use of cerebral protection is now captured. Now, Tavor mortality is improving steadily. However, 30-day mortality is a bit flat recently over the past 3 years, as you can see. The 30-day mortality rate is the most important one. The 1-year mortality rate is actually coming down, and is reflective in the lower risk patient population. Why are Tavor outcomes improving? We're going to drill down a little bit, and the bottom line here is that we are getting a little bit better change in mix of patients with the intermediate and low risk, as well as better performance of the teams. So in this metric, the country is doing a very good job. Tavor mortality, as you can see, is categorized by risk here in these patients, and this is in-hospital mortality. So it's 2018 data, no difference in low risk versus immediate risk in 30-day mortality. Not sure if this is too cool, especially if it persists into 2020, that there's not a whole lot of difference between low and intermediate risk mortality rates. Tavor all-cause readmission. This is a very disturbing slide and some disturbing data in the sense that the 30-day readmission, all-cause readmission is 13.4%, and the one-year readmission is 47% as of 2017. We're just getting the 2018 national data in now. But this is not something that we're particularly proud of, and we need to improve it. It's probably because these patients are very old and they have CHF admissions, poor selection maybe, and this is not something this is something we need to improve on. But the data is the data. Alive and well is pretty good. We have, this is a definition, and this is patient related, so it's a good thing, and not physician related, or not physician determined, but patient determined. And 81% of all patients have a improved KCCQ score. So we're pretty proud of that. The problem is that there's no change. So the patients that do well, do well. This is a good slide showing that the disposition of patients to home has gone increased dramatically to 85% going home, which is good data. This is an important slide as this is kind of the reason why some of this is probably done still in in endo suites, and this is where the heart team with surgeons and cardiologists is an important concept, is that we still have kind of an occasional disasters. If you look at the data set, there's about a 1.7 to 2.1% catastrophic rate, and unfortunately, it's been kind of flat or stable over 3 years. It's pretty low, but it's not zero, and it's important, especially in low and intermediate risk patients. And it's that, at least in the United States, as you can see here, most Tavor procedures are done in a hybrid OR suite or a hybrid cath lab. Only 16% are done in a small standard cath labs. After the stroke problem, which has not changed, as I told you earlier, the other issue that is pretty serious in my opinion, and we're concerned about at the TVT Steering Committee and at the National TVT Registry, is the fact that pacemakers have not changed. You can see these data over many years, despite going from high risk to intermediate risk down to low risk, and despite the fact that we have new and improved devices, patients still have the same pacemaker risk, and this is a very worrisome trend, and maybe platform. This may be a platform issue. And even in low-risk patients, the 30-day pacemaker rate is 7.3%. So this is no change in 7 years and quite worrisome with 12% new pacemakers. And this is actually pretty similar to what we might see. This is the S3I TF group, which is probably the best group shown from the partner trial. And you can see that they had a 10.4% pacemaker rate in 1,000 patients. So we believe that this data is probably true and is a reflection of the entire country and not just a trial cohort, and literally thousands of patients. This is excellent. Patients do well. This is the NYHA data, and the country is improving, and these patients are improving. I would talk about the mitral replacements. TMVR mortality is pretty high. It's at 30-day at 7.9%, but it's decreased from a maximum of 11.7%. So I'm pretty much at the end. So what I want to do is talk real quickly about the Taverts outcome relationship. And the bottom line is that there is a little bit of an outcome relationship regarding volume outcomes in Tavor, which was shown by the registry, and this is important for national policy, 27% reduction. Same thing is true with morbidity. There is a volume outcome relationship, and I'll try to get to the end of this real quick. This shows that there is a problem with patient prosthesis mismatch. It's also true in Tavor, and this is a study looking at 62,000 patients, which was recently published. The data is pretty good. It should be. TVT registry is audited. 10% of all sites are audited every year, and the results are pretty good at 92%. So the data is believable. One of the things that they were doing at the TVT registry is going to a composite risk model for public reporting, which will be out in 2021. And this is a very positive step in within the registry for outcome research and quality. And for this group here, I think it was important to take a look at what actually is happening in the surgical world. The questionnaire was from which department is your Tavor program run? And there's a significant number out of cardiac surgery, but most of them are both cardiac surgery and cardiology, which I thought was pretty interesting. And a lot of surgeons are doing many parts of the Tavor operation in the United States, as you can see in this slide. So to finish, science tells us what we can do, guidelines tell us what we should do, registries tell us what we're actually doing. As you can see, there are some issues, but for the most part, things are getting better, although there are a couple of areas which are really pretty serious. So I'll leave it to that, and you can read the conclusions, but this is the data set from a very large US database. Thank you very much.
Thank you, Professor Bavaria. It was a nice, very nice presentation. So I want to join together with Professor Guyen my really great consideration for the effort that Professor Diosano had made to put up such a great program. And I also encourage all the attendees to vote because the ballot is on. So we want to see what is your opinion on the best way to assess aortic stenosis. And with that, I would move to the second speaker. Please try to stay on time. We have 13 minutes of talk. And I will introduce Professor Francesco Musumeci. He's the Chief and Director of the Cardiac Surgery and Transplant Unit at San Camillo Hospital in Rome. And he will talk to us about transcatheter aortic valve replacement and surgical aortic valve replacement in 2020. Okay, we have some problem in connecting with Francesco in Rome. I wonder if we can maybe Tom, can we make some consideration on the report of Joe Bavaria about the activity in United States? What is very difficult compared to Europe is the percentage of procedure which are conducted into hybrid OR. What do you think? I mean, if we have to move on the low risk, I think this will become mandatory. What is your opinion about that?
Was that for Tom or for me?
Oh, that's for both of you. Actually, for you, because you presented us a large amount of procedure done in hybrid. So what do you think for the future, for low risk and intermediate risk? This, I think, would be the most important issue here in Europe, especially.
Well, I think it doesn't make a difference whether in Europe or the United States. The fact of the matter is that when you look at a large data set that's the real deal, and not out of a clinical trial, the fact of the matter is that there's a 1.7 to 2.1% catastrophic rate, and that, especially if you're in low risk patients, that is something that's going to require immediate attention. And so I think that it's safer for the patients to be treated in a hybrid operating room or hybrid cath lab suite.
I agree.
Yeah.
I think low risk is a completely different kettle of fish. And I think one of the things that we really need to insist on with low risk is to not make premature judgment, because for low risk patients in particular, we really need long-term data. And as we're seeing from the Partner 3 and the Partner 2A intermediate trial, Tavor in intermediate risk patients in the long term, in the 4 or 5 year follow-up, may not be as good as surgery. So I think time will tell.
I agree, Tom. And in fact, this was we can touch this upon this on the discussion. And then so finally we have Francesco ready. So Francesco, please go on with your presentation. Thank you.
Thank you very much. Hello to everybody. Sorry, but we had some problems here with the connection. I've also joined to say thank you to Marco for this really great idea, which has brought all us together again after such a long period of rest. Well, the title that has given me is quite interesting. Where do we go from here? Well, I think Joe Baveri has given us very interesting insights on the real world of TAVI compared to surgery, because of most of the information we have are coming from prospective randomized trials and propensity score analysis, which usually look into very selected patients population. Just hold on a second for the... Yes. Yes. Sorry. If we look at the result of surgery today, I mean, we've got available. Just a second, here the slides. Yes. We've had in the surgical field a lot of improvement. Today we've got biological tissue that can last longer. We've got sutureless valve. And also minimally invasive techniques are expanding for aortic valve surgery. And as a whole, the results of surgery, both early and long term, are extremely good. The great advantage of TAVI is that the procedure can be performed percutaneously. There is no extracorporeal circulation. And also with regard to valve, both self-expandable and balloon expandable, we've seen a lot of innovation over the years, and today the technology has significantly reduced the incidence of complications related to this procedure. Recently, I mean, last year we had these two papers published. These are the results of two meta-analysis, two prospective randomized trials, which have looked at balloon expandable valve and the self-expandable valve into the low-risk patient population. Both trials have clearly demonstrated that there is a lower risk within the first year in terms of mortality and disabling stroke with TAVI compared with surgery. And on the basis of this data, few months later, the FDA approved TAVI also for the low-risk patient population with aortic valve stenosis. This has certainly been a breaking news, and of course, it is worth wondering where are we going to go from here now that TAVI has been approved also for the low-risk patient population. Well, I think we have to make some consideration. Well, is this really going to affect our practice? Are the surgeons really going to lose from their practice this huge field, which in fact has got itself the history of cardiac surgery? Well, let me make some considerations. If you look into these two trials, we have to see that, in fact, the population of patients is very selected, highly selected. In fact, if you see into the criteria, exclusion criteria, you can see that there are several anatomical points which were considered as exclusion criteria, such as severe LV calcium, adverse aortic root anatomy, annular sides which was not compatible with the sides of the TAVI valves. Also, all patients with bicuspid aortic valve were excluded from these trials. Were excluded also all patients who had a poor transfemoral access, patients with anomalous coronary artery, and patients in which there was a risk of prosthesis to patient mismatch. Not only that, but if you look to the both study, there was a significant difference in terms of concomitant procedure between TAVI and surgery. The TAVI group had only 8% concomitant procedure, which were mainly coronary angioplasty, when the surgical group, the concomitant procedure were present in 27% of patients, included surgery on other valves, on the left ventricle, on the aorta. So really major procedure associated to the TAVI. Of course, there was a significant difference between TAVI and surgery regarding mild or greater valvular regurgitation, and this has to be taken also into the light that within this study, patients with bicuspid aortic valve stenosis were excluded, and we know that aortic stenosis in a bicuspid valve setting is present in younger patients, and also with TAVI there is a higher rate of periprosthetic leak. With regard to permanent pacemaker implantation, specifically in the self-expandable valve group, there was the higher rate, significant rate of pacemaker implantation. And again, if we want to look into the low-risk patients population, we must keep in our mind that pacemaker in the long term can induce left ventricular dysfunction, and also the lead through the tricuspid valve can cause severe tricuspid regurgitation, which in the long term can also cause dysfunction of the right ventricle. So really, this study are limited in the patient assessment just within 1 year of time, and the authors of both trials, in fact, stated that we need at least a 10 years follow-up to draw some final conclusion regarding the really value of TAVI compared to surgery. So if you are going to look at long-term results of, if you look into the long-term results, we've got data on the high-risk population. If you look at these two papers, again, look into balloon expandable valve and self-expandable valve, what we can see is that, yes, in the early period there was better survival of the TAVI patients, but at 5 years there was really no difference in survival between TAVI and surgery. And these are the data from the 2-year TAVI trial, looking at intermediate risk patients, where you can see again better survival, lower rate of complication with the TAVI in the early phase, but at 2 years, the two lines just overlap on each other, showing again that there is no difference between the two procedures. Similar results have been found in this paper that we presented last year at the European Society of Cardiac Surgery meeting, where we, with this meta-analysis, demonstrated that between 0 and 12 months, the mortality was lower in the TAVI group. Between 12 and 40 months, there was no difference in mortality between surgery and TAVI, and after 40 months, the survival was much better in surgical patients compared to TAVI patients. And similar results, in fact, have been demonstrated in these 5-year results of the Partner 2 trial, again, looking to intermediate risk patients. The paper was presented by Turani at the TCT meeting last year in San Francisco and published on the New England Journal this January. But again, better results in the early phase in terms of death and disabling stroke with TAVI. But if we move toward the 2 years follow-up, the two lines are overlapping, and then the two lines are opening up with better results of surgery at 5 years compared to TAVI. And if we look specifically at this slide, then Turani presented, you can see that if we take as a starting point the 24 months, where the two lines are exactly overlapping, you can see that over the time, the two lines of survival start splitting up, which survive and disable stroke, which are much better in terms of results in the surgical patients compared to the TAVI patients. And we know that the rate of periprosthetic leak, if mild or more than mild, was lower in the surgical group, and the presence of periprosthetic leak affects long-term outcome. And another interesting data is that if you look at the ventricular ejection fraction, again, at the beginning, better function with TAVI compared to surgery, but at 5 years, left ventricular function was much better in the surgical patients compared to the TAVI patients. Not only that, but rehospitalization occurred more frequently after TAVI than after surgery, and also in the TAVI group, there was a higher rate of aortic valve reintervention. And this is the only meta-analysis that we have published on low-risk patients, comparing again the surgery versus TAVI. The follow-up period is only 2 years, and the sample size is quite small, only 6,000 patients. And again, if we look into the results here, once more, TAVI provides better outcome in terms of mortality and cardiovascular accident soon after the procedure. But then if we move at 2 years' time since the procedure, results of TAVI and surgery are equivalent. So the conclusion of this paper are that the follow-up is too short, the patients are too small in terms of sample size, therefore, so far there are no evidence to draw definitive conclusion that TAVI can be used routinely as an alternative to surgery in the low-risk population. The other point I want to make is we have to distinguish between low risk and low age. They are totally different concepts. In fact, if we take, for instance, a patient with 6-year-old as an example, probably if he goes for TAVI, because his life expectancy in his life may have more than one procedure, and we know from the literature that the valve-in-valve, exactly here, if you look at this, come back here. It's a bit slow. Yes. Exactly. Yes. If you go do a valve-in-valve procedure, particularly if self-expandable supraannular valve are used, then it can be quite difficult to get to the coroneostia. So we can get in the paradoxical situation where a patient in young age had a TAVI procedure, and then in elder age, if he develops coronary artery disease, he cannot have coronary angioplasty, and then will need surgery for his coronary artery disease. So basically, on the evidence that we have in the follow-up between 2 and 5 years, we can certainly say that with surgery there are less events, that with surgery there are less paravalvular leak regurgitation, and again, after surgery there are less valve-related hospitalization and aortic valve intervention. And probably the fact that patients with surgery had more concomitant procedures, this means that with surgery, other problems, such as other valve disease, ventricular problems, or dilatation, were treated at the same time, and this may have affected the better long-term survival after surgery compared to TAVI. On the other hand, we have to accept the fact that there are already used third-generation valve for TAVI, and this, of course, is going to bring further improvements in terms of potential complications related to TAVI procedure. That's why I think with what we've got available, it is not possible to come to some definitive conclusions. And that's why TAVI should not be denied a priori to elderly patients which are at low risk for surgery. But certainly, these patients need to be discussed within our team, considering all the limitations that today are present with TAVI. And I think these specific points should be highlighted if new guidelines are going to be produced in the near future. So with all this in mind, certainly today we can consider TAVI in low-risk patients which are older than 80 years of age. I think that's something that has to be accepted. But I think we have to consider that the journey of TAVI probably is still at its beginning. In fact, all the data that we have got available today may make us think that still the battle between TAVI and surgery is still open, or maybe this can be just the final rise before TAVI is going to take over completely the treatment of aortic valve stenosis. Well, into my mind, really, what we really should look at in the future is not continue to compare TAVI and surgery, keep sort of arguing between the two procedures with the cardiologist, but in fact, look at something different, which is the new figure of the transcatheter cardiac surgeon. Because the transcatheter cardiac surgeon has got all the skill to perform aortic valve surgery, but also he can perform very safely transcatheter procedure. And I think the great advantage is that there is no bias of selection if the same professionist can perform both procedures. So if we look here some data regarding the aortic surgical procedure, we can see from the German database that the number over the years have been slowly going down, and also the recent published data from the National Inpatient Sample database from the USA is showing that the number of surgical cases are holding, but there is a steady increase, as we know, in the number of transcatheter procedure. That's why this is our personal experience in our unit. You can see we started TAVI transapical approach in 2009, and the number remained more or less steady. At the end of 2017, we started the transfemoral approach. You can see how in 2018 and 2019, the number of transfemoral approach really shooted straight up. And today, we are in the region, the center who performs the largest number of TAVI, even comparing with the cardiological units. And this is our photography of the activity on aortic valve stenosis. You can see how over 3 years we had a really significant increase in the number of procedures, and there has been a clear increase also in the number of TAVI, despite the fact that surgical cases have also increased as well. So, if this is again our practice last year, out of our aortic stenosis patient, 54% at the TAVI procedure, 41% a minimal invasive approach, and only 5% surgery through a full sternotomy. Among the TAVI group, 107 cases, 89% at the transfemoral approach, and 11% at the transapical approach. So really, if we want to give an answer to the question that I was asking to give an answer in this presentation, there is no doubt that if we want to go to the future of cardiac surgery, there is no doubt that the figure that has to be is the transcatheter cardiac surgeon. Thank you very much for your attention. Sorry for this problem during presentation. Thank you very much.
Thank you, Dr. Munisi, for a great presentation. We had a global perspective from Dr. Bavaria and Dr. Munisi. We're going to get a little more granular with Professor DeUciano, and his talk will be entitled 360 Degrees, Mini AVR, Going Beyond a Small Cut. Professor.
Thank you, Tom. If I can have my first slide. So, between 2017 and 2019, at our hospital, we have operated on 624 patients for an isolated surgical AVR, low-risk patients, all comers, where at 30 days, our mortality and stroke rate were 0.3% and 0.5%. So, while these results are much different and distant from those reported by the most important trials, comparing Tavor and Tavor in low-risk patients, these trials are reporting at 30 days mortality rates ranging between 1 and 1.3% and stroke rate ranging between 2.3 and 3.4%. I think that we can make some consideration. And the consideration is that when we have mortality and stroke rates that at 30 days are approaching 0%, we are entering in that condition of excellence, and I'm sure I'm not the only one being able to report these kind of results. That condition of excellence that allow us to rethink how we measure our outcomes in cardiac surgery, so that what we consider traditionally secondary clinical endpoints should become of primary importance, should become new major clinical endpoints in cardiac surgery. And I'm thinking about the surgical reduction of the trauma and the rapid recovery, the faster return to the normal activity, pain, cosmesis. When we have mortality and stroke rate that are approaching 0%, well, I believe these measures can really make the difference. And this is already like this for our patient. These variables have become key elements for our patient when choosing between different options of treatment. And I think that as a surgeon, we should not disregard that. I think that as a surgeons, if we target these new measures of variables and we learn to be better, to improve our results in terms of quality of life, perioperative quality of life, well, I think that at the end of the day, we will have done a very big step forward in our specialty. So I strongly believe that minimal invasive, for this reason, minimal invasive should become standard of care. I believe that surgeons should cover both minimal invasive and catheter-based approach. And I think that while we continue to generate excellent short and long-term clinical outcomes, we should also target and get concerned about perioperative quality of life of our patient and their families. So based on this principle, at my university hospital, we have put a lot of energies to make some progress, let's say. And so parallel to a significant increase of our surgical activity, we have empowered our minimal invasive program so that last year, in 2019, about 90% of all aortic valve were done minimal invasive, and about 2/3 of the mitral valve were done with a minimal invasive approach. Following the same principle, we've started a TAVI program in cardiac surgery. So we, as a cardiac surgeon, are doing the transfemoral TAVI by ourselves. Of course, we help each other with the cardiologists. We run when they need our help to fix some complication, and we ask their help when we have a high predicted risk of coronary occlusion. But we're doing by ourselves. And so in this way, we are able to cover all possible approaches for the aortic valve. We're doing the full sternotomy, which is extremely important. We do the mini sternotomy, the anterior mini thoracotomy. We have done some transaxillary, and we're doing the transcatheter as well, the transapical, the transaortic, and the 90% the transfemoral TAVI. But focusing on minimal invasive valve surgery, when we look at current lines of progress, we understand that most of the energies are put to reduce the trauma of the chest incision. We have a radicalization of the minimal invasive technique with the increasing support of endoscopic support. So we have mini sternotomy, mini thoracotomy, rib sparing mini thoracotomy, and endoscopic. So while the spectrum of these minimal invasive approaches are associated with less trauma, at the same time, they have they require longer operative times. There is an increased complexity, and probably dissemination will be decreased when techniques getting more complex and complex. So in our institution, while we're trying to take our techniques simple, direct vision, so that we have high dissemination inside our group, we're trying to give extra value to our minimal invasive intervention, investing on multidisciplinarity. In other words, we're trying to convert a minimal invasive intervention from a technique that is performed by a solo surgeon to a therapy that is provided by a multidisciplinary team. So while I think the surgeons with his or her reduced incision will remain the piano player here, I think that we have some other components of the band. Who? The perfusionist, we're asking them to use more and more minimal invasive extracorporeal circulation. And the anesthesiologist, we're asking them to be as less invasive as we are. We ultra-fast track anesthesia, which allows our patient to start immediate rehabilitation programs in the ICU 2-3 hours after, and to establish an immediate patient-family contact, which we learn is extremely important. So this is the result. You see, this is a 80-something years old lady, mini thoracotomy for an AVR. This is in the afternoon, and she's extubated, legs out of the bed, working with the physical therapist. And this is another picture. You see, this is a mini mitral 3 hours after surgery, extubated, working with a physical therapist, and we get the daughter beside. So while we are asking the daughter, the family member, to give support to the patient, at the same time, we improve the perception that the family have of surgery. We strongly believe this is being minimally invasive. We believe that this is as important as the length of a cut that we make it. So what we're doing, reduced incision, very shortly, we do all of them. Mini sternotomy, easy, fast, central cannulation. We're doing the David and the Bentals with this approach in the vast majority of cases. We're using mini thoracotomy, right anterior mini thoracotomy. I think osteoporosis, morbid obesity are a splendid indication. You need a more experienced surgeon and probably a favorable anatomy that you have to investigate with the CT scan. And again, this is our technique. For the sake of time, I don't have to show how we're doing, but it's important to remain direct vision and have perfect exposition of the valve. And this is the transaxillary mini thoracotomy approach. We've done few cases. I've learned this from Utz Kapper that will present this technique later on. And I've been impressed by how perpendicular is the view of the aortic valve from this approach. And this is the cosmetic results of this transaxillary, no visible incision from the front line. I think this is the most elegant approach for AVR, almost invisible. This is the skin incision for this operation. And MIEC, minimal invasive extracorporeal circulation, there are data published that MIEC compared to standard CPB is associated with less bleeding, less blood product consumption, better end organ protection, less atrial fibrillation, and also less mortality. So I think when mortality and stroke are approaching 0%, atrial fibrillation can really make the difference. And if we want to make improvements, if we want to make step forward, we have to care about these secondary complications. They're not secondary anymore. And this is in our experience about 300 minimal invasive AVR. We compare MIEC with standard CPB, and we had less bleeding, less transfusion, less atrial fibrillation, and more ultra-fast track anesthesia. This makes the difference to me. And ultra-fast track anesthesia. So what we're doing, we're extubating the patients on the table so that we have bed sitting, mobilization, respiratory therapy, and patient family contact already in the afternoon, soon after the intervention, so that the morning after, we can remove the drain. We start with oral feeding, respiratory therapy, bed and chair sitting, and if we can, in the younger, probably standing position. So this is an example, mini AVR, mini thoracotomy, 11:45. She's leaving extubated the OR. And this is in the afternoon, working with the physical therapist, extubated, legs out. And also, I'd like to mention what how the information to the family will change. So instead of saying, well, we have done it, nice operation, minimal invasive, small cut, the valve works well, we weaned off the pump very easily, but we have to wait. We have to wait till this evening or maybe tomorrow because the patient is sleeping. She's intubated. We don't know anything about the neurological outcome. Well, with fast track anesthesia, that will change. And you can say, we've done a minimal invasive intervention. All the team has worked in one direction, and that is minimal invasive. The patient is extubated. She's neurologically intact. Please, in 2 hours, go downstairs in our open ICU and look with your eyes. And you can stand close to your family. This is really meaning reducing the invasiveness of our operation. And this is what's happening, the physical therapist, the family, and myself. So ultra-fast track anesthesia, I'm very a believer. It allows early rehabilitation in the ICU, less postoperative delirium. We don't have our own data, but we're working to generate them. Establish immediate patient-family contact. It will reduce the ICU length of stay and intubation time in all patients. We have no problems when there is the need for that to transfer the patient from the ICU to the ward in the same operative day. And it will make our intervention and center more attractive because we are doing something different. We have an approach that goes beyond a small cut. We have a team approach. All components of the band are playing the same music, and that is minimally invasive. So our numbers, very quickly, last year, about 480 patients, 216 were the combined AVR. This means full sternotomy. We did only 24 full sternotomy, and these are the endocarditis and the bed redos. All the rest were minimally invasive. And Tavor, we did 92 Tavor in 2019. 90% transfemoral. And these are the results of our TAVI program, 140 so far, 83 years old, intermediate high-risk population, 30 days, stroke, pacemaker, PVL, and major vascular complication. Very well compared with benchmark results from the most important trials. I think this slide is showing that surgeons, and this is including our learning curve, so surgeons can do TAVR by ourselves very safely in a very efficient way. And this is our results with a minimal invasive AVR, and results are, as I mentioned earlier, 0 point. Mixed should be standard of care, no doubts about that. It should go beyond reducing incision. We can do more than a small cut when we're trying to be minimal invasive. And that means involving last valve and CPB technology. And in our hospital, it means to promote multidisciplinary teamwork with clear involvement of surgeons, anesthesiologists, perfusionists, nurses, physical therapists, and even families. And I think we should not just work to improve clinical endpoints, classic clinical endpoints, but also fasten patient recovery and get concerned about perioperative quality of life of patients and families. We call this 20-degree mix. And I'd like to close with this picture, this photo. This was taken at the Christmas party 2019. This is the team. You see myself. You see the chief anesthesiologist, Christopher Munch, the most serious person inside the hospital, probably a bit less when he's outside. I like this picture because everyone is smiling here. I believe that something special is happening in Ancona, and for this I'd like to thank all the team, all the group, and in particular the patients and the families that are giving us their trust. Thank you so much.
Thank you, Marco, for an excellent presentation. We're going to move on to the next session, the rapid fire. And the concept of the rapid fire is 5-minute, very concise presentations on a particular topic. And this is the poll that we had at the very beginning, comparing the preferred approach from our audience: mini sternotomy, right anterior mini thoracotomy, transaxillary or endoscopic approach. And it looks like from the poll beforehand that the preferred approach is right anterior mini thoracotomy. And the transaxillary, endoscopic, and mini sternotomy are relatively equal at roughly 20%. So with that, we'll move on with our next speaker from Sydney, Australia, Dr. Tristan Yan, and he will talk about mini sternotomy, why he does it that way. Dr. Yan.
Thank you, Tom. Can you hear me?
We can hear you.
Yeah. First of all, I'd like to thank Marco for your kind invitation. I've been given a very simple task to spend the next 5 minutes talking about mini sternotomy approach for aortic valve surgery. Let's get some basic points out of the way. I think mini sternotomy and mini thoracotomy both are very valid approaches for isolated aortic valve replacement. So cardiac surgeons should be familiar with both approaches and use them interchangeably. The mini sternotomy is a very versatile technique, not only for aortic valve replacement, but also it can be done for complex operations such as aortic root operations, ascending aortic operations, and aortic arch surgery. Now, at our institution, when we perform a right anterior mini thoracotomy, we're talking about a 3-centimeter incision at the surgical axis and a 3-centimeter femoral cannulation incision. We give antegrade custodial cardioplegia. The disadvantage of this approach is utilizing a retrograde perfusion, and we only can perform aortic valve replacement through this small incision. So why do I use a mini sternotomy? Well, I use both approaches, but in this talk, I'm going to highlight 10 reasons for using a mini sternotomy. Number one, it is safe and reliable. I use central aortic cannulation for aortic surgeon. That makes sense because it provides antegrade perfusion. You have absolute control of cannulation site. There's no risk of retrograde embolization or stroke. Number two, it is basic and simple. Anyone can do that. You can provide optimal myocardial protection, antegrade via the root or direct osteocannulation. I don't use the right superior pulmonary vein vent for simple aortic valve replacement or root replacement. The exact myocardial protection strategies is beyond the scope of this talk. Number three, it is small and clean, a 5-centimeter clean cut, no bleeding, no dirty groin issues, and no messy lung problems. And it is easy and enjoyable. As a surgeon, I like to set up an operation that makes the procedure more enjoyable for myself as well. So we developed this set of surgical instruments with Delacroix Chevalier. These are short-range surgical instruments and give you precise instrument control. You don't have to stand very far away using the long surgical instruments to perform something very simple like aortic valve replacement. So it's very simple and stable, has a very low profile, and the procedure is quite fast and enjoyable. Also, mini sternotomy gives you optimal exposure. You have excellent exposure of the aortic annulus, especially the right coronary annulus. You have a looking down the barrel view, and suture placement is very easy. There's also reduced risk of dislodging any calcium debris. And you have unlimited or unrestricted valve choice. You can use conventional aortic valves, rapid deployment valves, sutureless valves, or perform aortic valve repair. And also you can redo the rapid deployment valves. If the valves start to leak, you can change to a conventional valve very easily. So beyond valve, you can do a mini-access double valve, aortic valve and mitral. The mitral can be performed through a transaortic approach or through the superior approach via the left atrial roof. Beyond the mini-access double valve, you can do mini-access root replacement, such as mini-Bentel, utilizing the French cuff technique, or mini-access David procedure that we perform routinely via 5-centimeter access incision. And beyond the mini-access root replacement, going back one slide, beyond the mini-access root replacement, you can perform mini-access hemiarch replacement through a mini sternotomy, utilizing moderate hypothermia, antegrade cerebral perfusion, which is very simple, safe, and direct via this approach. And further than that, you can perform mini-access total arch and frozen elephant trunk through a mini sternotomy incision, utilizing branch first technique, zone 2 arch anastomosis, and a Thoraflex hypergraft deployment. As a matter of fact, we published a whole issue on this this month's Annals of Cardiothoracic Surgery, highlighting the techniques of frozen elephant trunk, utilizing the mini-access incisions. So you can check it out. Now, I have spoken about the 10 points. To me, it is really safe, reliable, basic, simple, small and clean, easy and enjoyable for the surgeons. You actually can have a very good exposure of the aortic valve, aortic root, and you have unrestricted valve choices. It is only possible if you want to do a mini arch or hemi-arch replacement or total arch replacement. It is only possible if you perform this mini sternotomy to the left side. That's the point I want to point out. Okay, and if you haven't tried the left-sided mini sternotomy, the exposure is much better than the right-sided mini sternotomy. Thank you for your time and attention.
Thank you, Professor Jan. Thank you so much. It was a very clear presentation, and I encourage all the attendees to vote if you have convinced them that mini sternotomy is the best way to get the aortic valve. And with that, so the poll is on, so you have to scroll down and to vote for your preference. And I move on with the next speaker, which is Dr. Marco Solinas. He is chairman of cardiac surgery at Ospedale Monasterio Massa, Pisa, Italy, and he will keep up the point of mini AVR, why he's doing it with right anterior mini thoracotomy. Go on, Marco.
Thank you, Mauro. Thank you, everybody, and thank you especially to Marco that gave me this opportunity. And for sure, I can't wait to come in person in Ancona, especially for the social event. But I've just 5 minutes, so I have to run. So why I perform AVR through right anterior thoracotomy? That still is just an evolution, and for us it was from our, let's say, historical minimal access that we start with mitral. When we would like to start also with the AVR, the thoracotomy seems our natural way. So which are the pros of right anterior thoracotomy? There is no sternal bleeding, so small pericardial incision and minimal manipulation of cardiac structure, and there is an easy and safe access to the ascending aorta, and this leads to a central cannulation. This is something that we prefer if it's possible, and is feasible also in reduced cases. The concern about this procedure that is needed a plan. There is some imaging, especially CT scan, that help us to select patients. Cross clamping, and to learn this, that for some people is let's say a difficult operation, is needed a mentoring. But which is the rationale to perform a right anterior thoracotomy? Obviously, is to reduce the surgical trauma, and reducing the surgical trauma, we will have some advantage that, according also to our previous speakers, nowadays we cannot just consider secondary. And reducing the trauma, these are not randomized trials. These are institutional experience that compare mini AVR right thoracotomy versus full sternotomy. We can have also an advantage in terms of mortality. So also in the hard point, we can impact our patients. And looking always to literature, there is no possibility, let's say, we don't harm the patient, we will choose between right thoracotomy and mini sternotomy, that there is no statistical difference in terms of survival or disadvantage. So we can really think that in 2020 to take a CT scan to our patient is really harming the patient. In my personal consideration, to have information, anatomical information like this one, can just make the operation safer. So I don't think that this is a concern anymore. And we were quite let's say, lucky because in 2010 we had the possibility to use new technologies, and new technology means new frontiers. For sure, rapid deployment prosthesis, sutureless prosthesis, the core knot system makes this operation easier for sure, and spread indication. We are much more liberal nowadays in choosing the patient, and more or less with this we can proceed to almost every patient. And in terms of crossing, using this technology, we were able to really low down our cross clamping time from almost 87 minutes to 50 minutes. So, oh, excuse me. Okay, so this is how we do it. We do a right thoracotomy in the second intercostal space 90% of the time, very close to the sternum, and you can see that if you need, you can also, you are not, you don't need to sacrifice the mammary artery. As we said before, we try to cannulate and do a central cannulation of the ascending aorta and a percutaneous cannulation of the femoral vein for the drainage. The aorta is just there, so it's easy and safe to cannulate the aorta from the right anterior thoracotomy. Obviously, we perform then our aortotomy, and the valve should be, the view is, let's say, with some tips and tricks, we can have a very nice visualization of the prosthesis. And after that, you can choose the prosthesis that the patient deserves. You want to use a sutureless, a rapid deployment, a standard one. It doesn't matter. This comes with the experience of the surgeon, with the anatomy of the patient. This is a choice that you can do, and you can plan also on the basis of the CT scan. When the prosthesis is parachute and in place, the only thing that we have to do, obviously, is to close the aorta, and you can see that the exposition of the valve is incredibly good, and let's say also using a standard prosthesis, we can have excellent results. So because of lack of time, I go further. So this is the result after 2 months. This is from an aesthetical point of view. Also, if obviously transaxillary could be also better than this aesthetical result. And I have to say the truth, I'm starting my program also here in Massa. But the other concern, is this teachable? We have got to make some study in our institution in terms of learning curve and transfer, and how can we transfer the surgical skills to the young surgeon. And with a teaching program, this is feasible, and the learning curve is very flat, and everybody can do it. So at the end, right anterior thoracotomy is feasible, reproducible, teachable, and learnable. It's cost-effective, safe for the patient, and comparable for sure to other minimally invasive technique, and better than full sternotomy, especially in some subgroup of patients like obese, like frail patient, old patient, and what I have to say more, sorry, excuse me. Thank you very much for your time and attention.
Thank you, Dr. Salinas. I wanted to encourage the audience and attendees to submit questions. We're going to have a discussion period after the next several talks and try to address your questions. Without further ado, I'd like to introduce our next speaker, Dr. Kappert from Dresden, Germany, and his preferred approach is a transaxillary approach for minimally invasive aortic valve replacement. Dr. Kappert.
Hello, everybody. I hope you can hear me here.
We can hear you.
Can you hear me? Yes? Okay, it's my honor.
Yes, perfectly.
Perfect. Marco, first of all, thank you very much for the invitation. It is an honor to dedicate the next 5 minutes to the question mini AVR, why I do a transaxillary. So first of all, I have to say that this is not only a technique. For me, it should be an integral part of a mini-invasive concept for an aortic valve replacement. And when minimally invasive surgery is done under direct vision like we do it, for me it is an imperative conclusion to go the more lateral way. So the advantages are apparent. First of all, it is a sternal no-touch technique to preserve the integrity of the entire shoulder girdle. Ribs kept untouched, no sacrifice of the memory. The procedure is done under direct vision without any optical gimmicks, and therefore more reproducible for everyone who wants to do it too, and it helps to train a special team enormously. The last and most important point for the patient is the cosmesis with nearly no visible scars in front of the patient, as you can see in the picture. So make procedure safe, simple, and successful, we have to know everything about the anatomical conditions. So a CT scan is performed in every patient, and based on the 3D reconstruction, any aspects can be considered to make the procedures more reproducible and more predictable. This mainly affects by the type and kind of aortotomy, vertically, longitudinally, localization of the cardioplegia, cross-clamping level, height of incision, and the result often confirms the prediction and gives an unbelievable good exposure. So everything can be defined before actual surgery. There are some more points to consider to make the procedure much easier. First of all, it is a javelin thrower position. So the patient is positioned on the table as almost in the CT scans. The incision is made in the third or fourth intercostal space in the right anterior axillary line. Femoral cannulation we use in every patient, sometimes percutaneously, but normally we use a cut-down technique. We use a special tissue retractor, special stay sutures, thanks to Joseph Lamelas, vent, cross-clamping, and the conventional AVR is done in a conventional manner. Rapid deployment valves are definitely in the foreground, but as you could see, all other valves can be safely implanted. So after all that, the most important advantage follows. What I cannot see the next slide. Oh, I have to use my iPhone, sorry. So after all that, the most important advantage follows. With that transaxillary approach, more than an AVR is possible. A mitral or the combination, tricuspid, mitral tricuspid in combination, ventile procedure. In special selected cases, you can go for an isolated ascending replacement. And this is what we call one access approach with nearly no visible scars in front of the patient. So all this could only be developed of the basis of great experiences. What you can see here is a dynamic description which starts in the year 2014, which was a year where we start our true mini-invasive program at the Heart Center Dresden. The isolated AVR is described and includes 4,552 cases. The trend is clear. and shows a 95% share of mini-invasive aortic valve replacements or catheter-based implants in 2019. So this result is thanks to a good team that goes beyond just one. So I have to conclude this was only the tip of the iceberg. And as I said it in the introduction, the transaxillary approach is not only a technique, it should be an integral part of a whole mini-invasive concept. And yes, surgeons should be aware of their position and strengths to be able to master all these techniques in their entirety. So thank you very much for the attention.
Thank you, Professor Kappert. It was a very interesting presentation with this new way of approaching the aortic valve. I will move to the next presentation with Dr. Salvador. He's presenting us the more, I would say, the less invasive way to address the aortic valve. Please, Loris, go ahead.
To me, this is a friendly presentation, just showing our technique, our style in Vicenza. So why endoscopic? Because integrating, I realized that integrating the latest technologies and the endoscopy, virtually all patients can be operated without sedation and for isolation of multiple valve disease. And Vicenza is the town of Palladio. Palladian style was widespread around the Western world. So working in the town, we decided to have our style. This is the setting for the endoscopy IVR in Vicenza. It's quite simple. There's a walking port, a bedline, the thoracoscope, and the aortic clamp. And the key points are the screen monitoring, indirect vision, no rib resection, and the right mammary sparing. In our protocol, no CT scan is mandatory, and we make no selection with patients. So this is the Vicenza style. No, this is not minimally invasive. In our opinion, this is the style that we adopt in Vicenza. So from here to here, the step is quite small. And let's go with a few very short movies. Nowadays, with all the new technologies, as Marco Salinas says, we can reach any aortic valve in these settings. As you can see, it's a quite clean field, and this is the hole for the thoracoscope, and the other hole was for the vent. At this point, we are going with the cheat wood to clamp the aorta. At this point, we are opening the aorta, and we are going inside the aorta to make sure everything is fine. This is the Perceval implant. So we use the same technique of the sternotomy with three stitches, and as you can see, everything is done under indirect vision on the screen. The good thing is really the magnifying imaging that you can have with this technique. At the end, of course, it's not a matter of centimeters, but can help on the good acceptance of the operation by the patient. From the Perceval, we are going to see almost with the same approach. Is 3-4 centimeters incision is far from the sternum, so it's not necessary to care about the mammary artery. So here's the sizing of the valve, the 3 stitches as usual, and this is the rapid deployment valve. This is how it works in our hands, and we think that with the endoscopy, we feel comfortable because we don't pay attention about the the closet space. This is the final check, and from here is quite intuitive to go in the next step, right? Because we are familiar with the endoscope. This is the triple valve replacement through the same incision. This is the left tracheotomy. In this case, we perform the repair. And this is the water test for the mitral. Then we went to the tricuspid valve. Okay, nothing to say, just to put a ring. Okay, and the next, of course, is for the aortic valve replacement. As you could see in the previous video. In this case, we put in the aortic position the deployment valve. So quickly, what can I say? This technique, the endoscopy, give us the opportunity to have a good dominion of the situation. This is the nice thing that you can check if the after deployment bias prosthesis is sitting very well on the aortic valve. And going ahead, of course, with this endoscopy technique, we tried in the beginning. This is I'm sure that it's a movie for only the ascending aorta replacement, but usually we do aortic ascending aorta replacement concomitant to the aortic valve replacement. This is a very strange case to find only aortic valve, ascending aorta replacement, but it's good the movie, so I proposed it to you. So at this point, what can I say? Endoscopy is, of course, is a long way. It's not easy. So you need to have a very nice experience a very long experience on mitral valve repairs or surgery anyway by endoscopic technique. But when you are familiar with the technique, I think that you reach very good results in this field. So I think that now this is the population we had is around 20 to 264 patients. Most of them isolated, some 74 concomitant. As you can see, ascending aorta replacement in 11, 32 mitral surgeries, triple valves in 7. And this is the prosthetic valve we used. And we are going to finish. The Vicenza protocol is this. Under 60, 65 years, we use intuitive stented by prosthesis mechanical. Above 70 or 65 years, if the aorta is regular, we use any period prosthesis at any age. If the sinus tubular junction or ascending aorta is slightly dilated, we use intuitive stented valves. And extremely small annulus or other patients, we use Percival. We published in our first 125 cases since September 2018. We found very good results with this technique. The mortality is very low, 8. We studied also another population, the obese patients. That is quite challenging patient, but the mortality was 0, was good, results were good. So, and of course, this year, because of the COVID-19, we couldn't go to present our 264 patients to the ATS meeting. So, what can I say? These are the pitfall of the endoscopic technique: miniaturization, better visualization than direct vision, no resection, sparing the right artery mammary, no mandatory CT scan in our hands. We do no patient selection. We do concomitant procedure. The CT scan usually we adopt when we have some specific suspect or with dilated aorta at the coronary angiogram. So we finish at this point. Thank you.
to the pool, or what do you think? Or maybe we should start a discussion afterwards. Okay.
Sure. I think if we can, so what we did was we had a baseline poll to see what the audience thought about their approach. If we could pull up the poll question again, and this is after everybody's presentation, and it looks like there's a strong preference for mini sternotomy.
Great.
A huge from before and after. It's very interesting. We'd also like to encourage the attendees to submit chat questions. We'll try to get to as many as possible. We want to make this engaging and as interactive as possible. I'd like to start off, if we can get the panel up with all the previous speakers, please, and we're going to have a panel discussion. Thank you. I wanted to start off with a question about Bavaria. You know, the TVT database is very unique because it contains transcatheter information. The STS database is very unique because it contains surgical information. But what would be even better is if we had a merger of the database, so we could really directly compare transcatheter versus surgery. So my question, what will it take, or has there been dialogue about potentially merging the STS and TVT registry? And then the other question is, will it ever be possible to create perhaps a global registry? Is that a pie-in-the-sky idea, or is it something that we could potentially work towards, collaborating with the STS and EACTS and our other our societies? I can hear you.
And is a little bit political. As you know, the TVT registry is an ACC STS endeavor and will require some collaboration at the legal level between the ACC and the STS to be able to merge the data sets for research purposes on a large scale. That is in discussions right now at the board level between the STS and the ACC. So we're hoping that this will happen in the very near future, so that we can press on with very, very robust and huge data sets of over 1 million patients for this. So it's not here yet, but it's coming. The second question is obviously something that we're looking at. The only thing I can say right now that's in the works and that is online, so to speak, is a data harmonization and data sharing, so to speak, between the TVT registry and the Japanese TVT. The Japanese TVT utilized the same data elements as the TVT, so the two data sets of the two countries are highly compatible. The TVT registry, from the standpoint of governance, the steering committee absolutely has no problem with sharing or harmonizing with any national data set in any other country in the globe.
The question from Germany directed at you, Dr. Bavaria, and his question is there a limit, an age limit for Tavern and low-risk patients? What are your thoughts on that? Perhaps we can get the panel to chime in as well. So we'll have Dr. Bavaria respond first and see what the panel thinks. Is there an age limit for Tavor and low-risk patients?
Well, I don't think there is an age limit. And it's certainly from a standpoint of the law, of what we here in the United States look at as available or legal, so to speak, to do. There's no age limit. The trials obviously have very limited data on anybody less than 65. So it is a little bit of an experiment to place TAVRs in patients less than 65 to answer this question. But when we look at the TVT database, there are certainly patients less than 65 in the database. So I would say that, and it's been discussed in some of these presentations, that if you're less than 65, certainly you need a very robust heart team discussion because there basically is no data.
What about the panel?
Okay.
Should there be an age? Should it be illegal to do a TAVR on a 55-year-old or a 60-year-old, otherwise low risk? Marco, you do Tavor, you do Saver. What do you think?
We cannot hear you, Marco. We can.
I'm sorry, I was muted. Yeah. If the
Well,
question was because I had some problem with the some noise, but if the question was, would I go for a Tavor in a 65 years old patient, then this is an easy question to me, and the answer would be no. I would go for Saver all my life. No, there is no doubts about that. There is no doubts about that. We don't have data. We have excellent outcomes, durable outcomes with surgical AVR. So this is Saver. 65 is Saver. 75 is Saver, unless there are no complications, no comorbidities that are increasing the risk.
okay, Marco, that's very clear. Yeah, Professor Kapper?
Yes, and you have to think about that these are two different medical strategies. One is an aortic valve replacement. It is in a replacement. You put the old diseased valve out. On the other is methodically only an implantation. And so for me, there is no discussion to discuss put TAVI in the younger generation. Yep. You have to go for a conventional strategy, and it is very important to go in that kind of patients for a conventional aortic valve replacement, not for only implantation. That is not a palliation.
Yeah. Can I make a comment? Hello,
Yeah.
can you hear
Francesco,
me?
go ahead.
Yes.
Yes, Francesco, go ahead.
We do, as you know, we do both TAVI and surgery. And honestly, today evidence, I think, in a low-risk patient with no other comorbidity, below 80 years of age, I think it's very hard to do TAVI. We would prefer to go for conventional surgery. The results are certainly good, but there is no evidence at the moment that TAVI is going to be better. I think in a younger patients, probably will need more than one procedure. And therefore, I think, as the literature is showing, TAVI in TAVI may then have some problems in accessing the coronary ostia. So if the patient develops coronary artery disease, I mean, this can be a bit of a problem doing coronary angioplasty. So results with surgery are extremely good today. With minimally invasive approach, we've got a very low mortality. We've got excellent long-term results. So still, unless this patient is an elderly patient, consider surgery as a first option in low-risk patients. And as you said, we have a very large TAVI practice.
Marco?
Yes?
Marco,
Also, I think that I think we should consider a couple of very interesting slides from Joe Bavaria showing that stroke rates and pacemaker have not been improving so much over the last 3 or 4 years. So this is something really important. We should not forget when we're considering TAVR in a younger patient. And then I don't want to spoil the second part of this session, but we do not have data about long-term data about valve-in-valve. So when proposing a valve-in-valve as a second procedure after SAVR in younger patients, we're proposing something that we don't really know very well in the long run. So younger patients, I think conventional surgery remains the best option.
Yes. I think, of course, life expectancy is a very important point. You see, in Rome, we did the youngest patients with a TAVI was a 23-year-old patient, just published, but in fact he had progeria syndrome. So his life expectancy, of course, is not very long. So in this case, TAVI was the only suitable option. But again, I think it's very important to look at life expectancy before making the decision, unless the patient is, of course, is a high risk.
Thank you, Dr. Salinas.
Well, just a quick comment. I think that I don't think that the age is really important, but a low-risk patient with an active life, also if he's 75, we had incredible 75 chap that play tennis, golf, they love to swim and enjoy life. and give to these people 50% chance to have pacemaker and 12% chance to have a major leak, I don't think that is wise at the moment. When we will have different data, probably we can spread the indication to lower risk, but I don't think that we are in that phase at the moment.
I think that's why I think it's very important the concept of the transcatheter cardiac surgeon, having the possibility of choosing the procedure. I think you can make a much, say, balanced choice for individual patients, which is the best treatment. I think that's really the next step. We, as a cardiac surgeon, should take completely over the TAVI approach. It is not a complicated procedure. The only concern may be coronary artery occlusion, but again, this is a very, very, very rare complication, and you can really predict before the procedure if there is a potential risk. So in our experience, on over 500 TAVI, only 3 or 4 times we felt the potential occlusion of the coronary artery, and we asked the cardiologist to come in and to put a guide into the left main, and only in one case we had to expand the stent because of the potential occlusion of the left main stem. But otherwise, really, this is not a major problem. So I think it's having this clear in mind. Really, surgeon is the best person as a practitioner. I think cardiologists have taken over the TAVI because at the beginning, surgeon refused this procedure. But believe me, I think this is really the way to go. We should very much go into this procedure. I think it belongs to us, and we can really make the best specific decision on each individual patient. I think this, who is really pushing toward younger age are the cardiologists. That's why I think they want really to take over. And I think today is totally unethical, into my mind, to push TAVI in younger patients, below certainly 75.
Let's change gears a little bit. Dr. McCurry, you mentioned cerebral protection in your talk. My question for you is, should this be the standard cerebral protection, especially in low-risk patients? And I want to expand it to the panelists to see how many of their centers routinely do cerebral protection for their Tavor patients. That's very, very
We don't.
Marbled.
Sure.
But I think that we have no data right now. The TVT registry has 30 or 40,000 patients right now with the cerebral protection devices in place, and we will be doing a very robust analysis in multiple domains of that device with probably 40 or 50,000 patients on each side. So we'll see what happens. It obviously will be a very important publication. So I don't think we have the answers right now. I mean, at our place, we're doing cerebral protection in almost everybody, especially younger and low and intermediate risk patients. But that's just what we're doing.
Dr. Marco Usano.
We've done a little number of Tavor, 140 so far, in about 1 year and something. We not use cerebral protection at all. We had 0 stroke. Probably we were a little bit lucky, and we're going to use cerebral protection in selected cases. But what we've done is using cerebral protection systems in open surgery. So this is an example of hybrid surgery, an example of how important is that surgeons learn to manipulate these catheters and this technology in order to improve their outcomes in open surgery. So we've done, I think, 7 or 8 cases so far, very bad calcified aorta. They were too young and unfit for Tavor or for other percutaneous procedure. So we decided to operate on them using the Sentinel Claret system. And so far, those 7 or 8 patients had the perfect neurological outcome. Some were extubated on the table. So this is to say that pushing surgeons to learn how to use catheters, because it will help expanding indication to open surgery and improve outcomes in selected patients, high risk.
it certainly makes sense. It's intuitive to use cerebral protection for open surgery as well. Just a show of hands from the panelists, how many routinely use cerebral protection for their Tavers? If you could raise your hand, routinely for all Tavor patients. So one out of 7 or 8. Okay.
I see you have a lot
Dr.
of money, Joe, in your institution.
Yeah.
Yeah, we're very rich.
Right, good for you.
That's why. Yeah. Yeah.
Dr. Yan,
Tom, there are
questions.
Yeah. Go ahead, Tom.
There's several
I'm sorry.
questions.
I had
Yes, please, Thomas.
a question also for Dr. Yan.
From Switzerland, and from Jasmine from Switzerland, how do you vent LV when doing a mini sternotomy?
I routinely vent the LV through the aortic annulus. Just put down a pediatric drop vent through the aortic annulus.
And there is
Corey
another
Adams
question for you. Sorry.
Yep.
Yeah. For you, Dr. Yan, you were talking about mini sternotomy on the left side. Can you? It's quite unusual for many of us. Can you expand a little bit on that? It's really gives a better exposure of the valve.
Yeah, I believe so. How it came about is my first mini surgical procedure was mini arch and frozen elephant trunk. So for that, I had to go to the left side because exposure of the arch was much easier in my mind. And ever since I've done a left-sided sternotomy, it seems that it is the right way to do because it gives you access to the proximal arch. And especially even for a right-sided mini sternotomy, sometimes the right coronary annulus is hidden under the main plate, main sternal plate. So it's difficult sometimes to place the sutures under the main sternal plate when you have a right-sided mini sternotomy. With the left-sided mini sternotomy, the whole minor plate lifts up and it gives you a perfect exposure of the aortic annulus. It's always like looking down the barrel view. So I have never regretted it doing the left-sided mini sternotomy, and that probably is 98% of my mini sternotomy cases all to the left side. And you can do root, proximal arch, and total arch through that incision. The right side it's very difficult sometimes.
Thank you.
Dr. Capper.
Many...
Sure, Dr. Capper. There's some questions. Sophia Martin from Italy. She says, state pericardial sutures are crucial for good exposure, but frequently venous drainage significantly worsens. Do you notice this problem? How do you manage it? Dr. Capper.
Oh, sorry. Can you repeat the question, please? I did not understand this.
Sure. The question essentially is, how do you manage decreased venous drainage because of potential decrease in venous drainage because of retraction sutures?
This is really a good question, and you can only perform a good surgery with a good drainaged heart. So we use a special cannula. This is a very strong white one from DLP Medtronic cannula. It's a 28 French cannula, and so it is a continuous perfuse cannula, and so it is possible to drainage this cava superior and the cava inferior system together. So we have no problems with the venous drainage systems. Yeah.
And do you only drain from the groin? Do you drain from the IJ as well? The IVC?
Yes,
both.
IVC we use as well as in case of tricuspid surgery, yeah, or in combination if you go for mitral or tricuspid. All other cases we drainage with via the groins.
What about the rest of the panel? Do you for your minimally invasive approach, do you routinely drain with the SVC with an IJ cannula as well? If you do, raise your hand.
Sorry?
I'm polling the rest of the panelists if they routinely drain via the SVC. How many panelists routinely drain the SVC? You raise your hand.
No.
No.
But we drain only the SVC if we go for a tricuspid
Right.
Yeah, of course.
surgery. Yeah, of
Of
course.
course. Yeah, of course.
For,
Of course.
for mitral and for aortic, it is only we use a normal standard cannula. It is introduced by the femorals. But SVC only for tricuspid or for ASD or for something like this. What I want to
Of course.
say is that it is always the same approach. It is surgery under direct vision. It is always the right side. It is always in the right anterior axillary line. Only the intercostal space differed a little bit. It's the third, fourth, sometimes the fifth intercostal space.
I would
Okay.
add that Medtronic actually has a bicable pin you can use through the groin as well. It has a space in the middle, so you can go through the groin and just snare the SVC and IVC, and not necessarily have to do an IJ as well. That's another potential option. Let's move on to the next session. Again, thank you all panelists for excellent presentations and excellent discussion, and thank you for all the attendees for submitting the questions. Dr. Rinaldi, will you present the next, introduce the next presenter, please?
Yes, Tom. Together with Professor Bavaria, we will be moderating next session, and the first presentation is by Mauro Cassese, who will talk to us about if TAVI is done by a cardiac surgeon is as good as TAVI done by a cardiologist. So, Mauro, you are a cardiac surgeon. I guess the answer.
Unfortunately, I think it would be different from what you think about. But anyway, good evening, everybody. And I wish to thank you, Professor De Usanio, for the invitation, the organizing committee, and CTSNet for broadcasting, and obviously my moderators. So the question is if us as cardiac surgeons can perform TAVR with results at least as good as our colleagues, interventionalists. So before giving the answer, I think it's important to understand for us that we are in front of a recurring theme for cardiac surgeons, which is a paradigm shifting like we had in PCI versus CABG, or we are facing with endovascular procedures for thoracic aorta versus open surgery. But in this case, there is some peculiarity that make the comparison between surgical AVR and TAV a very difficult match for the surgeon. The surgeon is on one part of the field and is a lone player in an unbalanced match where three other components are playing against him, trying to exclude completely him from the game. And this is the patient who obviously wants the procedure as less invasive as possible. The industry, which has a breakthrough technology and knows perfectly that has a big economical drive and income. And obviously our direct competitor, which is the cardiologist, the interventional cardiologist, which has the referral, has the skillness, and has the diagnostic tools in his hands, and wants more leadership and seeks also a career growth. So it's a very difficult game to play, and we should think about this, and we should react. We should react as soon as possible, also because in the heart team, we are not playing a role which is at least as important like the cardiologist, and all the other players know that. So next, have the next one. Okay, sorry. There is some delay. So in my experience, I want to dispel directly any doubt. In my experience, the answer to the question is certainly yes. And I can tell that because I started the program, Transcatheter program, operated by surgeons only 11 years ago, 2009, We performed more than 1,500 Tavor procedures during these years, only by surgeons with no interventionalist at all. And furthermore, I personally proctored more than 700 procedures worldwide. So I can witness that we, as a surgeon, we certainly can answer yes. And obviously we have an unbiased indication and approach, and this was underscored by Professor Musumeci, and we are still gatekeeper of the patient affected of valve disease. We can solve almost all possible complications. And next, the real question is, if we are doing mini AVR, either a mini sternotomy or mini thoracotomy or a transaxillary or whatever, why don't we cannot do a TAVR procedure? This is the real question that we as cardiac surgeons we should think about and should give an answer to this. And when we started this procedure, you can see that immediately after 1 year and a half, we were doing double valve replacement. So this is another witnessing that we, like a surgeon, are ready to do also some advancement. At that time, doing a double valve one-stop procedure was almost impossible for everybody, especially for the interventionalists. And with the old XT valve and the same introducer sheet, transapically, we changed 2 valve in this lady who was an 81-year-old lady with 2 magna. And I remember her because we was our first double valve replacement, and we shouldn't actually know really well also the problem of LVOT obstruction. So we went almost very difficult situation. And this was the final result of the procedure. So this pushed us toward more and more cardiac transcatheter procedures. Next year, in the year 2012, we were doing a procedure in a 54-year-old male, Terre 2 AVR, with no calcium at all, aortic regurgitation 4+, ejection fraction 25% in a stentless valve, a freedom solo that everybody of us today know that is a very difficult valve for this kind of valve in valve, especially when no calcium and no coronary ostia are known. And this was the final result, which was very good. So all these things just to understand that we can witness after so many years that for sure we can. But I have also to confess that I believe that we are very late. And going back to the discussion when Dr. Goyen asked us what to do about a 64-year-old male, I would say for sure I would go for surgery, but what the patient wants and what the cardiologists who send to you the patients in the next future want. That is very important. It's not only the song that we are singing by ourselves, and it's not a sing that we can do only by surgeons. We should take into consideration many other factors. So it's not important what only we think, but we have also to understand which is the belief and the willingness of the other 2 counterparts that are the patient and the cardiologists. So we are very late, I believe, and Dr. Nguyen asked us if the surgeon can still get a ticket to treat structural heart disease. And I think this is the real question. Are we still in time to get this ticket, or we are too late and we cannot do anything anymore for this? So to answer this crucial question, I think we should we should understand which were actually the reasons why surgeons arrive so late to do transcatheter half-valve therapies. So the first is the complete absence of training resources, both for imaging, either intraoperative or preoperative, fluoro, angio, CT scan, and also for catheters and wires and the use of them, and the absence, complete absence of a structural training programs or accredited certifications that there are not still today in the year 2020. The other crucial thing is that we need to train senior staff, not only young surgeons, because young surgeons can stay at the table with the interventionalist, they can assist him, but they are not yet they are not really able to take part of the procedure in the way a senior surgeon can do. And only, in my belief, senior surgeon can have the charisma to keep in our hands Tavr, but they should also have the time to retrain. So this poses a question for the surgeon. If we want to stay on Transcatheter, we have also to find time to retrain ourselves. The second reason we arrive so late is the absence of a good quality imaging in our operating theaters. Almost anybody of us 10 years ago had an hybrid room or an high quality imaging in the operating theaters. So as a surgeons, we were guests in the cath lab, and still today we are guests in the cath lab. And if we work as guests, we never get the job. Future strongly depends on training and facilities. This is my operating theater, a fully hybrid room done in the year 2015, but my first tentative to have a facility like this dates back to the year 2010, in which we anyway have a biplanar angiography in the operating theater. We didn't have a table who was able to do all the movements, but we had very good imaging also at that time. The third reason is the most important, absolutely, is that the older surgeon need to abandon the comfort zone of traditional AVR, either mini-invasive or standard sternotomy, because this has been a losing strategy in delaying the clinical application of Tavor in our surgical practice. Where are we today? We are still in the comfort zone. We are at the border of the fear zone, and we are intimidated to go in this area because we know there are eventually a lack of confidence to enter this fear zone, and we find excuses not to enter this zone. And in this way, we never be in the learning zone. The few surgeons that arrived in the learning zone with Transcatheter, they immediately went to the growth zone. So this means that we have to jump and not to have fear to do that. This is the most important thing for me. The next slide is reassuming which are the thought and the surgical reactions, emotional reactions that accompanied for 20 years the raising and the establishing of TAVI in our armamentarium. So you see, there is no one single emotional reaction which was positive, only negative reactions. So we cannot be player of this game if we continue to have only negative reactions. So this year and the last year for me are the last call to action, and either we go ahead or will be very difficult to us to enter the next future. So if we were doing just 4 years ago, sorry, I have to go back. If we were doing a valving ring in mitral, transapical, today we cannot do any more of that. And we have to go in transeptal. So the educational gap it's increasing, because the need to know all the catheters and even the transseptal punctures is a new thing that is not in the surgical armamentarium. So we have to understand this, that the gap in intervention is going very, very fast. This is an example in which we have a balloon septostomy, and then with a 14 French balloon, and then we enter with a Sapien 3 valve transeptal, and we just went in and we lose coaxiality, as you see, but we were still able to push a valve inside this very difficult ring, which was an Etilogics, which has a very strange shape, and you know that. And it is a very difficult case in which we close also a pseudoaneurysm of the aortic root with coils. If you see the black mass over here. And today we are no more doing this procedure transapically. As you see, we do it transeptal. And when we do double valve replacement, we are not doing it anymore transapical, but we are using a combination of transseptal mitral valve replacement. You see here an example in which we went with 2 wires in the ventricle, 2 stiff wires, to have a very good coaxiality. One was a body wire, and next, transfemorally, arterial transfemoral, we went to make a valve-in-valve transaortic. So we changed also the approaches that we are using to do these procedures. And surgeon must be aware of this. So finally, the answer to the initial question that Marco gave to me is certainly yes. We surgeons are able to do everything, but we should become fully independent in TAV. This is my personal thought. We cannot rely on cardiologists, first of all, because there will be no interventional cardiologist who will act as a Tavr trainer for cardiac surgeon. And this is the first reason. The second is that in the next future, surgery will be pushed potentially out of the heart team. And you should believe this, because they are giving an approach which is more and more minimalistic, is not only percutaneous, is, as you see, as Dr. Bavaria showed us, they are able to dismiss the patient from the hospital on the first postoperative day. And I'm asking also which is the role today of the ACTS and STS, because nobody has given us a positional statement on which is the role of surgeons in TAVR, and we still do not have any idea of an educational training or a certification for surgery and for surgeons to do TAVR. In my last sorry, but I have to go to next, okay? The conclusion. I would like to conclude with this slide in which I show a patient that I treated 2-3 years ago. She was a lady that came to us with a Star Edwards ball cage in mitral position, positioned more than 30 years before in the United States, and a Magna valve which was positioned in Italy, in the north of Italy, 15 years before, Magna in tricuspid. And she came to us with a tricuspid valve which was degenerated and in the need of aortic valve replacement because of stenosis. And we did this job that you can see. So this patient for me represents herself a 50 years history of valve replacement in which surgeons have been leaders of valve replacement, whatever. And we must aim, in my idea, remain protagonists. And to do that, we have to fully embrace transcatheter valve therapies, which are the natural evolution of open surgical techniques. Thank you.
Thank you so much. Thank you, Mauro. Professor Bavaria, you want to comment on that?
Well, I think that we have. That was an incredibly provocative talk. My personal opinion is that we did maybe make some mistakes, especially in Europe, I believe, early on in Tavor, regarding kind of governance of Tavor and those kinds of things. We learned more here in the United States, where we do have a law which has come down from the government of the United States to mandate heart team involvement with both cardiologists and cardiac surgeons as equal members. It is mandated by law, and bottom line is you don't get paid unless there are two operative notes, one from the cardiologist and one from the cardiac surgeon. So we are in a better position for cardiac surgeons in the U.S. The heart team, while under stress, is considered the norm, and I believe that some of our best results will be with both cardiologists and cardiac surgeons working together in all phases, both operatively and preoperatively in Tavor. That's my personal opinion. One really interesting point is that the big Russo paper, which came out, which was about cardiologists, cardiac surgeons, and just operators in general, regarding their ability to have good outcomes. And what it showed was really interesting, that it didn't make any difference whether the lead operator was a surgeon or a cardiologist, but as long as you had one operator who had a lot of experience, patients did fine either way. And in many cases, that one operator was the surgeon who had the most experience. So I suppose that's my comments on this paper. We'll have a discussion later, I presume. I think we should go ahead maybe and look at the next talk. Yeah. Is that correct?
Yeah, correct, Professor Bavaria. Before presenting the next mini session, there is another ballot here, and since the two following presentation will treat about reoperative aortic valve intervention, so you should vote whether for you to go with the valve-in-valve or to do with a redo mini AVR possibly. So in the meantime that you take the scroll and you vote, I introduce the next speaker, which was my previous co-moderator, Professor Guyen, and he will take the part of valve-in-valve for best reoperative aortic valve intervention. Tom?
Thank you, Tom.
Tom, we cannot hear you. We cannot hear you, Tom. We cannot hear you. Okay.
Yep. Thank you, Dr. Rinaldi and Dr. Desiano. I was tasked to defend the best reoperative approach for AV intervention is valve-in-valve, and these are my disclosures. But probably the most important disclosure is that I am a minimally invasive valve surgeon. I enjoy operating. I enjoy getting my hands wet, but I also enjoy doing transcatheter therapies as well. That's me as a primary operator in a novel transcatheter mitral device. So again, that is my disclosure. I think I have feet in both camps and appreciate the pros and cons of both. But before I want to set the stage for the debate, I know that there are good actors and there are bad actors. Tom Hanks is a good actor. Steven Seagal is a bad actor. And the way the question is framed, Dr. Mattia Glauber is going to defend the reoperation approach. Dr. Glauber is a good actor and I'm the bad actor. And I'm going to try to convince you that some actors can become good actors by 3 points. So first, I think it's pretty clear that less is more, and it's embedded in our psychology, whether we like it or not. I'm going to try to show some data that valve-in-valve is respectable and improving. And then lastly, I'm going to try to suggest that don't forget about valve fracturing. So let's move on. It's pretty clear we live in the world of wires. I'm sitting right here in Houston, and Dr. Luciano and many of the team is in Italy. And it's clear that we're not going to escape the world of wires that we're living in right now. It's also pretty clear that we're living in a new era of Tavor. In the top left is Mick Jagger dancing 6 weeks after Tavor. I would argue that even through a minimally invasive approach, it's hard to have someone dance like that 6 weeks after having a mini AVR through any approach. The top panel shows Tavor growth in the United States. We're now operating not only in septenarians, octogenarians, nonagenarians, but also centenarians with pretty good results. I like Tavor. Tavor is not only the future, but it's already the present. I like to show this slide, and I steal it often from Dr. Bavaria. But what I really want to say is that when Dr. Bavaria first presented this slide, what he said was, it's no longer Tavor. Take out the T, just call it AVR. So hopefully when Dr. Bavaria was voting, he voted for me in the poll that came up. So let's say it's flu season. If you need a vaccination, would you prefer to get a vaccine by this small needle here or a slightly bigger needle as you see here? It's intuitive. And what if I were to tell you that the smaller needle was just as good as the big needle, or even if the small needle wasn't as good? I think it's pretty clear that most would probably prefer the small needle. To date, I've never had anyone come to my office begging me for a sternotomy. It just doesn't happen. And it probably doesn't happen in your office as well. This is how we've done surgery in the past, and this is how we're going to do surgery in the present and future through a transcatheter approach and through minimally invasive approach. I think it's going to be the standard of care. But this just shows how much it's embedded in our psychology. This is a very famous Marshmallow Experiment at Stanford, and the premise of the experiment was essentially this. They went into a room and gave a child one marshmallow, and they said that you can sit there and not eat the marshmallow. If you wait 10 minutes, you'll get 2 marshmallows, or you can eat the 1 marshmallow right now. As you can imagine, most of the kids and maybe even the adults would just eat the 1 marshmallow, even knowing that later on they actually could get 2 marshmallows down the line. The point of me saying this is that the psychology of humans is that we often prefer kind of short-term gain, for better or worse, but it's pretty clear that's the psychology that we're dealing with. So less is more. I'm going to try to show you some data that valve-in-valve is respectable. And this was data presented by Dr. Kaneko of the Brigham at the recent virtual AATS. Dr. Bavaria showed this slide. Essentially, we're seeing an increase in Tavor, but we're also seeing an increase in valve-in-valve. It's not going anywhere anytime soon. And repeat surgery is not inconsequential. It's not necessarily an easy operation. This is a study that presented published in Annals of Thoracic Surgery in 2015 using the STS National Database. And what they found was an operative mortality of 4.7%. So that's not trivial by any means. The mean STS score is relatively intermediate risk at 5.5, and a relatively high pacemaker implantation rate of 11.5%. So what the group did here was they used the readmission database, started off with roughly 6,800 patients, did one-to-one propensity matching, and compared roughly 2,100 reoperation Tavor patients versus valve-in-valve. And this is what they found. On the primary outcomes, looking at morbidity and mortality, primary outcomes, unadjusted, multivariate, propensity matching, all favored Tavor in their analysis. When they looked at secondary outcomes, major bleeding favored Tavor, both in unadjusted, multivariate, and propensity matching. When they started to look at disposition and costs, a higher number of patients went home after Tavor. They had a shorter length of stay and potentially lower costs if they had a valve-in-valve as opposed to redo AVR. Again, outcomes for reoperative AVR is not inconsequential. In a standard using the STS database, for a primary AVR, the mortality is roughly 2.2%, and a reop is roughly 4.6%. So again, it's not necessarily an easy operation to do reop AVR. Again, most of us do it all the time, but when you compare it to a slightly lower potential complication with valve-in-valve. This is a meta-analysis study looking at 342 patients, 5 studies, and they looked at procedural mortality, they looked at stroke, pacemaker implantation, 30-day cardiovascular mortality, acute kidney injury, bleeding, and guess what? they all favored valve and valve as opposed to re-op AVR. And you might say, well, hey, this is actually presented in a cardiology journal by cardiologists. No, this is actually presented in one of our journals, the European Journal of Cardiothoracic Surgery. So there's actually data presented in a surgical journal supporting or potentially supporting valve and valve. So I'll agree, there might be an argument that valve and valve results in increased postoperative gradient, as you can see here, greater than 20 millimeters of mercury. And I guess this favors surgery. And we know this with the transcatheter valve and valve registry. 28% of patients had a valve who underwent valve and valve had a gradient greater than 20. The mean postoperative valve and valve gradient was 15. But I would actually argue that the problem isn't necessarily the technology. The problem here is actually the surgeon, because 29% of the failed surgical valves were less than 21 millimeters. So the burden is upon us to put the largest surgical valve possible during the first operation. And we know that because in the valve and valve registry, if the valve is small, the mortality was high, roughly 25%. But if the valve was smaller, it was large, the mortality was significantly lower, roughly 7%. So again, I think the burden is upon us. And lastly, I want to wrap up, don't forget about valve fracturing. A lot of this was spearheaded by Keith Allen and his group. And as you see here, here's a video, there was a video of a valve fracturing. I'll move forward with that, but essentially the valve fracturing fractures the frame of the valve, and as you see here, the valve that was fractured with a sword and mitral flow, and they cut the fabric, and you see a fractured frame. Here are the results from the valve fracturing: no coronary occlusions, no annular ruptures, no pacemaker implantations, no AI, 2 minor strokes with no residual stroke, 1 chordal tear that was eventually treated with mitral clip, 2 severe AI from disruption of Tavor valve, treated successfully with a second valve in valve. Just as a refresher, these are the valves that can be fractured. There are a lot of valves out there, but it's probably easier to remember the valves that cannot be fractured. So if a patient comes in with needing a valve in valve, the very first question I ask is what valve was implanted, and something to potentially consider. Edwards has a valve that has been purposely designed to expand to potentially accommodate valve in valve technology. One thing that I thought was very fascinating about the valve fracturing is the valve fracturing actually expands and makes the valve bigger. So here you have a 23 millimeter Medtronic Evolute inside a 21 millimeter Magna. As you see by the measurement, it's 19 millimeters. But after the valve fracturing, the measurement ends up being 22.9 millimeters. So what happened was this 21 millimeter Magna valve now has a near 23 millimeter OD just after fracturing. So again, here you have a 23 millimeter Edwards Sapien XT inside a 21 millimeter Magna. After fracturing, it's now 23 millimeters. So this 21 millimeter Magna now has a 23 millimeter OD after valve fracturing. Before valve fracturing, as you see here, there's a pinwheeling effect with the leaflets as they open. And then after valve fracturing, there's less of that pinwheeling effect. And the thought is, we don't have the data, but the thought is potentially this could decrease the risk of structural valve deterioration after you fracture the valve. This remains to be seen. What about long-term data? This was presented at the recent ACC virtual conference looking at 1-year data. And it looks like the hemodynamics remain stable at 1 year after you fracture the valve, as you can see here with this figure, mean gradient at 12 months. So again, I hope to try to convince you less is more. It's embedded in our psychology. The valve and valve data is respectable and improving. And I think it's important to not forget about valve fracturing. But I also want to add, I want to sneak in another point. I think surgeons need to be involved with wires, and this was discussed at a prior presentation. I think this is really more the fundamental topic, not whether or not we should do valve and valve or whether we should do re-op surgery. I think it's more that surgeons need to be involved with wire skills. I think I know we can because we have to. It's imperative for us to do this. These are some interesting mitral devices on the market: the mitral clip, CardioQ, Harpoon, Neocord, CardioBand. What do these devices have in common? All these devices were invented by surgeons, but interestingly, the adoption has mainly been by cardiology. So again, I think it's important for us to be involved in innovation, but also be involved with the adoption of this technology. Last couple of slides, I think it's important for us to have a change in mindset. So this is a surgeon and cardiologist walking, let's say in Kona, Italy, and let's say you ask him a question. And the question is, what's the best way to address aortic stenosis? Well, of course, the surgeon, because we're trained to, we're going to say the best way to approach is a re-op AVR. The cardiologist, well, of course, they're going to say clearly it's valve and valve. But I'll be provocative a little bit. And let's say you measure their IQ or their intelligence level. Well, a surgeon's IQ is maybe 120. And this cardiologist IQ is maybe 115, a little bit lower. But the reality is, you know, and we might say the cardiologists aren't as smart as us. They're pretty smart people out there. And it's not necessarily that they're not smarter than us. The point of this slide is we choose our treatment approach based off our training and where we're from, not by our intelligence, right? If you're trained as a cardiologist, you're going to choose a valve-in-valve approach. If you're trained as a surgeon, you're going to choose a reoperation approach. But what the other question is, let's change it a little bit. What do the patients want? Well, if you ask a patient, a surgeon asks a patient, they're going to say valve and valve. You ask a cardiologist, well, they're going to say valve and valve. Lastly, what about the workforce? Ultimately, we're outnumbered against cardiologists. In the United States, total number of cardiothoracic surgeons, 4,000. Total number of cardiologists, 3,100. So if there's one surgeon, you're surrounded by 8 cardiologists. That's a ratio we're looking at. So we're outnumbered there, guys. We can't fight them. We can't say this is all bad. We need to find a way to embrace the technology, work closely with our cardiology colleagues. So I started off with good actors and bad actors. As you see here, there are good actors, there are bad actors. I think the way the question was framed, Dr. Glauber was a good actor, and I'm kind of a volleyball out there. But sometimes I think good actors or bad actors can become good actors, and hopefully I was able to persuade you with this point. Again, thank you for your attention, and I appreciate you joining us in this virtual conference.
Thank you very much, Professor Guyen. And now Matthias Glauber will take the lead for the Redo Mini AVR. Matthias, go ahead. You are a good actor.
Can you hear me? Is my microphone unmuted?
Okay. Yes, it's perfect. Nice. Thank you. Perfect. Thank you, Matthias.
So thank you all. And first of all, I'm very honored to be part of this faculty for the first Ancona Live meeting. And I would like to thank Professor Deusanio, the organizing committee, and the rest of the faculty. So now I will try to be not only a good actor, but even a good, let's say, thinking doctor, and try to give the right question, the answer to the right question. So I was asked to cover this exciting topic and answer to this question. If surgery still has a place in Redo AVR, and especially in mixed AVR, if this can be beneficial or even superior. It's to answer this, we have, my slide is going forward. To answer this question, some issue should be considered every time we have to decide which approach we have to choose so as to be a good actor. So first of all, we have to consider the history of the patient, and especially the type of previous surgery. Obviously, it makes a difference if the patient had a CABG or if he had an AVR, and it's even important to know which valve was implanted previously, or if he had a mitral procedure and he only has an aortic stenosis. So history and type of surgery is very important. Then we have to really assess the risk of the procedure and to establish which comorbidity can impair the outcome of the patient. of the procedure. And at least we need to know exactly the anatomy derived especially from the CT assessment, which especially for Redo is very important. The rationale to do a minimal invasive, these are my disclosures. The rationale to do a Redo surgical AVR with a minimal invasive procedure was discussed in this meta-analysis, which concludes that mixed AVR is at least as safe as full sternotomy, with all the other clinical advantages that we can see in non-Redo mixed AVR. So like less transfusion, less bleeding, less prolonged ventilation, lower infection rate, and lower hospital stay and mortality. The next aspect that we have to consider, and which makes the difference in outcome, is the type of approach. So we have to decide between a partial J hemisternotomy or a right thoracotomy, with, in my opinion, a preference for right thoracotomy when anatomy and technical aspects are favorable. And here we can see some decision making, but we have to tailor for each patient the best approach, combining all the information and technical consideration we have to consider in terms of perfusion strategy, myocardial protection strategy, neurological risk, and so on. So in this video, I will, which is, in my opinion, a challenging video. I try to, let's start now. So let's the video start. Okay. I will discuss many of the technical aspects that I consider for Redo. This is 80 years old, so quite old patient who had a previous AVR with a 19 mitral flow valve and with a severe aortic regurgitation due to degeneration, bioprosthetic degeneration. We even had a severe stenosis, and at the angio, we had also the proximal LID stenosis. CT scan is surely not favorable for a right thoracotomy, but even not favorable for a partial sternotomy due to the adhesion on the sternum. So here we are in the second space with a 4 centimeter skin incision. Then we start to approach the dissection of the aorta and to make the aorta free from the sternum, to approach the first dissection. Then we go on pump to unpressurize the aorta and to finalize the preparation of the aorta for clamping. And seeing that we have aortic regurgitation and a small prosthesis, a better visualization can be obtained with a vent from the right superior pulmonary vein, and aortic clamp is obtained with a direct cross clamping with the detachable clamp. This is not the Chitwood clamp. This is my personal design clamp. And once the aorta is empty, and I'm sure that the aorta is well depressurized and well clamped, I perform the aortotomy. and I go selective first in the left and then in the right coronary ostia. The most difficult aspect is when I have a small prosthesis to remove all the single sutures so as to obtain the free sewing ring of the prosthesis, so that after having removed every single stitch, I can, with a dissector, remove the valve and obtain the anatomical annulus, which has to be cleaned from every single plaget, every single overgrowth of tissue, and pannus should be removed so as to have a clean annulus. And you see how the aorta is free from the sternum, and it's free to move. And seeing that we had a small annulus, a sutureless valve was the first choice, either because of the easier technical implant, faster implant, and even better orifice areas that we can obtain. Every single tear in the annulus is detected, and if present, we have to repair it and suture it. What I was able to implant was a medium valve, so in a 19 mitral flow, I was without air and over sizing, I was able to implant a medium sized valve. So this was even an important improving in orifice area of this patient. So we did not have any major bleeding, no need for transfusion, excellent postoperative performance of the valve, and the patient was discharged on the 5th postoperative day. So this was surely a tricky case, but we obviously need to think to the other option. So TAVI represents the real minimal invasive approach, so can be really the good actor, but some limitation should be kept in mind. And in my opinion, the most important is related to the potential risk of patient prosthesis mismatch and the lower survival related to this, or eventually to a higher post-implant gradient. And in this paper, Danny DeVere showed the relationship of survival in either a small annulus or a medium annulus at 1 year. And this is an aspect that play an important role in the decision-making, even if we can consider the cracking of the annulus. The next two slides shows that valve-in-valve has a lower survival even without a post-implant prosthesis mismatch. And these are other slides, which, okay, there was a delay, sorry. Even in case of higher surgical risk, but I quickly come to the conclusion. Full sternotomy redo AVR sets the basis of excellent surgical result that can even be better with a mixed approach, but if performed in experienced centers with minimal invasive and even by experienced hands. And TAVI is surely a good option for inoperable and high-risk patient, considering the size of the previous prosthesis, so that in future, even when we will have data on durability in long term, we can probably enlarge the indication of Tavor, but still, actually, we can procure or bring good data in our candidates for a redo AVR. So thank you for this opportunity, and I thank you very much.
Thank you, Mattia. A terrific case. I mean, very difficult one.
Yes,
thank you, Mattia.
I forgot to tell that the patient had later a PCI performed 3 months later
for
on
the LID,
proximal
for
LID.
the LID.
Yes.
Yeah.
Yes.
Right.
Thank you so much. And then before we start a very, very short discussion, because we are a little bit late, I want to see the pool, please. Can you? Okay, you have been convincing, but not so much, Mattia. Most of the people think that valve-in-valve can be the favorite approach in a redo case, and that's, of course, is very, very much understandable. In a situation of very small annulus, of course, a good surgery can still be a very, very nice approach. So maybe Joe, you want to lead the discussion? Yes. There are many questions.
Yeah, I would be glad to lead the discussion. We have exactly 7 minutes left. I'm glad everybody's on the line here, and we see everybody. We have some questions from all over the world. It's very interesting about what we have. So let me start off with a question from Lee in the United States to Tom Nguyen. I totally agree that surgeons should and can do Tavor, but how would surgeon get the training? Do you really believe that V&V with valve fracture is a good option compared to redo Tavor in low and intermediate risk patients? Tom?
Thank you, Dr. Bavaria. I agree. It's difficult to get training and also difficult to be involved in procedures, particularly because the cardiologists are often the gatekeepers. But this is where I think as surgeons, we need to know the data better than the cardiologist so that we can be in there and be able to articulate the pros and cons of a transcatheter approach and surgical approach. So I think that's the first way. We need to know the data. As far as training, I think sometimes surgeons feel that, they want to be in a cath lab, they just want to show up. And it's hard to because we have a lot of other cases going, but it's going to take an investment on our side. So as surgeons, we need to be committed in making that investment to show up in the cath lab. And maybe the first time you show up, you're not going to be able to do a whole lot. But just as a medical student showing up, it's not like you can show up and be able to do things. But I think eventually, if you demonstrate that you're part of the team, you know the data, you'll be there. And I think the cardiologists will be very receptive to training. And that's one aspect of on-the-site training. The societies that I know Dr. Bavaria is involved with, and we're involved with the board and the ACGME, we are trying to change the training paradigm a little bit so that residents can finish and be facile at transcatheter approaches, because we know it's the future. We know that we have to because we need to. So that's something to be stay tuned about. Dr. David Fullerton is actually spearheading that effort.
That's very good. Thank you. So I have a question from Lee in China for Dr. Glauber. In redo AVR, removing degenerative valve prosthesis may damage the valve annulus. Do you believe sutureless AVR is a viable option in these patients?
obviously we can choose any type of prosthesis, but in case of a damaged annulus, we need to repair the annulus. So it's not possible to just deploy a valve with a tear in the annulus. And what I do is with a single pollen suture, I reconstruct stitch by stitch where the tear is so as to repair it. This before deploying the valve. Without doing this, we have to implant a sutured valve in a conventional way and reconstruct the annulus while placing the metres suture with or without pledgets.
That's a very good question, Dr. Lee from China. Thank you very much. Good answer, Mattia. So another question from Dr. Akash from India for Dr. Kassisi. Doctor, which approach for Tavor, which approach for patients who cannot receive TF implantation? And Tom, you can also answer that one. But Professor Kassisis?
So after TF TAVI, my second approach is TA TAVI. And I still believe transapical done in the right way, really mini invasive, is a very good approach. If we go to mitral, I told you today I go transeptal. But if it's related to the aortic valve, my first is transfemoral. 95% of cases, the other are transapical. There is a little number in which I can do other approaches like transaortic or transubclavian.
Yeah, I would say that I would say that from the database in the United States anyway, that transcarotid and transsubclavian are becoming very, very popular in the United States for Dr. Akash from India. Tom, real quickly.
I agree. Essentially, the TVT database has shown that TA Tavor has gone down, and now the preferred alternative access has been transaxillary, but now transcarotid is making a run for it. So the now two preferred alternative access in the U.S., according to the TVT database, is transaxillary and transcarotid.
Okay, so I have a question we have 2 minutes left. I have a question from both Antonio in Italy, as well as Dr. Machat from Canada, which are basically the same, which is, how can we be independent when cardiologists are the gatekeepers? And how do we relate to cardiologists if we're going to build our own program? So Dr. Kassisis first, and maybe Tom second.
Okay, so to be independent, the first thing I told is to have a high quality imaging in the operating theater, to become autonomous and not to be guests in other places like the cath lab. This is essential. Is the first thing. The second is to have a skillness, to acquire a skillness in wires and catheters. And the third is that the senior staff of the hospital should be engaged and embrace the obviously all the transcatheter therapies.
Thank you. Tom, real quick, because I have to finish up here.
So it's obvious, I think you need to be willing to do the procedure. 2, I think you need support from societies and all the associations. In the U.S., for Tavor, we have CMS requirement that a surgeon and a cardiologist be involved. We don't have as much aggressive traction for the mitral space. I think it's important to do so. So we need support from societies and industry in that respect. And the last thing, what I alluded to in my previous comment, is I think it's important for us to know the data and be able to articulate the data. We can't go there and push our way in and not necessarily know the data for the pros and cons of both.
Well, thank you very much. I would like to thank all three of you for your great presentations, and my co-moderator, Dr. Rinaldi. And I believe at this time, we would like to take it back to the program director, Dr. Marco Desunio from Ancona. Dr. Desunio.
We cannot hear you, Marco.
There you go.
Marco, yeah. We cannot hear you.
Good.
No, we cannot.
Mark, can you guys hear me?
Yeah, we
Everybody
can
can
hear
hear
you. It's Marco that is
Marco.
probably switch off he muted the phone. Okay.
Can you
Okay,
hear
go
me
ahead,
now?
Thank
Marco.
you.
Yeah, perfect.
Yes.
Yeah, so thank you, Joe. Thank you, Mauro, for your moderation, and thank you to all the faculty members that you can see here with their city, with their home city as a background. I think it was a very nice afternoon. We spent 2 hours and a half together discussing about how surgeons should remain key players in the management of patients with valve disease, in particular with the aortic valve disease, and that is putting a lot of energies on minimal invasive approaches and transcatheter, because this is what our patients are asking. So today it was the aortic valve. Tomorrow at the same hour it will be about the mitral valve. We will have important faculty members as well. We have, I think, a very exciting program. So please be with us tomorrow at the same hour for the mitral valve session. Thank you to all of us, and thank you for watching. Thank you so much.